You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for December 15th, 2017. This week, a breakthrough in catheter ablation, a ICD lead update. What is the best NOAC? How about HDL infection risk and fibrosis in male triathletes? First up is a story on VT ablation. Now it's only 5 patients, but it may be the beginning of a new era in catheter ablation. Imagine this for a second. An ablation procedure that takes only 14 minutes, involves no vascular access, no sedation, and yes, it seemed to work. A team at Washington University in St. Louis used stereotactic body radiation therapy to deliver ablation to the left ventricle of patients having refractory scar-related ventricular tachycardia. New England Journal of Medicine published this series. The methods are remarkable because not only did they use radiation therapy, but they also did the mapping completely non-invasively. Patients underwent either a CT scan or an MRI, and then they had their VT induced with an ICD lead, not an invasive EP study, and also had non-invasive mapping of the ventricular tachycardia with a 256 electrode vest. The combination of the imaging and the vest allowed localization of where to deliver the radiation therapy. Now remember, the ultimate purpose of standard catheter ablation with either RF or cryo is to destroy the injured living remnants of myocardium within scar areas of the heart. It's these areas within the scar that form channels that allow reentry. That's where scar-related ventricular tachycardia comes from. Also remember that one of the most recent techniques pioneered by Dr. Natali's group is called scar homogenation, which means identifying the area of the scar, let's say it's inferior scar, this is low voltage areas that have fractionated electrograms, and then ablating the entire area. Basically, you pull up a chair and millimeter by millimeter you burn until the entire diseased area of scar is ablated. And then if you ablate the entire area, you're likely to get all of the channels that could cause VT. But this approach, the Washington University approach, basically does scar homogenation, but instead of with an invasive catheter procedure, they did it with radiation beams from the outside. Now, with catheter ablation, we use a catheter and sometimes intracardiac echo to map out the scar. The Washington University team did this with imaging and the electrode vest. The therapy seemed to work. In these 5 patients, the ventricular tachycardia burden went down dramatically. And impressively, these were sick patients without much hope of any other therapy. The procedures also seemed safe. There were not any significant major complications. One patient had a fatal stroke 3 weeks after the procedure, but she also had tons of risk factors for embolic stroke. Of course, it's important here to remain skeptical and cautious. This will have to be replicated in bigger studies. But oh my, ablating the heart non-invasively, that, my friends, is so cool. The second story is a quick update on the St. Jude Medical Riata lead. Now, St. Jude Medical is now Abbott, but you remember that the Riata lead issue began about 6 years ago. There was a Class 1 recall of this ICD lead. Now, using a Canadian registry, investigators reported 10-year performance of more than 1,300 Riata leads and 110 lead revision procedures. Key findings from the Heart Rhythm publication included that the rates of the electrical failures of these leads keeps increasing. So that suggests that the dwell time should be considered in the decision to revise the lead. Another finding was that during the 110 lead revisions, which were done for various reasons, complications occurred in about 8% of cases and was more than double when leads were extracted rather than abandoned. This, I believe, is the most relevant finding of this study. When you do a lead revision, there's a choice between just adding another lead and abandoning the lead that's not working, or adding another lead and extracting the lead that isn't working. And lead abandonment versus extraction is a matter of great debate in electrophysiology. Now, the Riata lead is special because it's known to be hard to extract. But the point here is that I think leaving leads alone and abandoning leads isn't always as bad as the extractors say. The final point here goes beyond any specific lead issues, and it is the notion that device implants come with complications. It's always good to reiterate the fact that ICDs are not like insurance policies. When you buy an insurance policy, you don't incur any risk from the insurance policy itself, and that's different with ICDs. ICDs come with risks. Third topic is the best non-vitamin K oral antagonist. I'm often asked what is the best non-vitamin K oral antagonist or NOAC drug. Patients want to know which one is better. Doctors want to know which one is better. And it's tempting to compare studies of NOACs versus warfarin and trying to figure out which one is best. In fact, this is what a group of researchers from the UK tried to do. They published in the BMJ, and they culled 23 RCTs involving about 95,000 patients in which a NOAC was compared to warfarin. The study is called a network meta-analysis, and they found, after lots of statistics, that apixaban got the edge. And I think apixaban is fine, but I also think rivaroxaban is fine, and dabigatran too is probably fine, though I must say that I slightly favor the factor Xa inhibitors. I also think without a direct comparison, which isn't likely to happen, it's never going to be possible to tell which NOAC is better. Fourth topic, HDL and infection risk. This is an interesting one that I didn't know about before. Now, raising HDL levels with drugs doesn't seem to work to reduce the risk of cardiac events. But a new study from Denmark may indicate that HDL plays an important role in the immune system. The European Heart Journal published this interesting observational study of about 100,000 individuals from the Copenhagen general population and about 10,000 individuals from the Copenhagen City Heart Study. The primary endpoint of this observational study was infectious disease requiring hospital admission. And the authors found a U-shaped association. They did lots of multifactorial adjustments in individuals with HDL cholesterols that were below 31 and above 100 has hazard ratios for any infection of 1.75 and 1.43 compared with those HDL levels that were more in the normal range. In the smaller Copenhagen City Heart Study, the association with higher infectious risk was only seen with low HDL, not the higher HDL. Now, I had not heard of this relationship, and the authors spent a great deal of time in the discussion section making the plausibility argument. They wrote that the HDL has been shown in preclinical studies to have several mechanisms that could influence functioning of the immune system. For instance, HDL inhibits proliferation of stem cells in the bone marrow. And interestingly, in the Illuminate trial with CTEP inhibitor torcetrapib, the torcetrapib group with elevated HDL cholesterol had more infectious disease-related deaths than the placebo group with lower HDLs, 9 versus 0. Now, this might reflect a qualitative difference in HDL raised in response to CTEP inhibitors, different from that of ambient HDL measured in the general population. Also, it's well known that HDL cholesterols show an inverse correlation with concentrations of triglycerides. The authors knew this, and they adjusted for triglycerides in a multifactorial way, and they found that concentrations of triglycerides were not associated with the risk of infectious disease. Now, of course, this is an observational study, and unmeasured confounding is possible. In fact, reverse causation here is a possibility. Nonetheless, this is a somewhat novel observation with plausible mechanisms, and one that certainly deserves further study. Final topic today is about myocardial fibrosis in triathletes. This was a small abstract from a radiology meeting recently that studied triathletes, and it raised a lot of attention. It was a group from Hamburg, Germany that performed cardiac MRI in 55 male and 30 women triathletes, and they found simply that the evidence of fibrosis in 18% of men, none of the women. They also found that training volume and the number of completed Ironman races seemed to correlate with fibrosis. This is a small observational study, and gadolinium enhancement is certainly a surrogate outcome measure. But still, there's a precedent here both in animal models and human models that training volume could possibly lead to adverse structural remodeling of both the atrium and the ventricle. Now, this group plans to do more follow-up in these patients to see if this translates into clinical outcomes. I also think, and I've talked to Nasir Marouche about this, that I think doing serial MRI scans in athletes would be a fruitful avenue of research to study whether or not there is adverse remodeling with excessive endurance exercise. That's it for this week in cardiology. I'm grateful that you listened. Thank you. We are going to take a 3-week break, so the last 2 weeks in December and the first week in January we'll take for holiday break and return in the second week of January. I hope you all have good holidays.
You're listening to This Week in Cardiology from theheart.org on Medscape.